Psychiatric documentation is the one of the most important clinical skills for psychiatric practice. Good documentation is communicate clinical reasoning, support the continuum of care, meets the legal and regulation standards, justifies medical necessary for treatment and billing. So psychiatric documentation is one of the most important clinical skills for psychiatric practice. Good documentation communicates clinical reasoning, supports continuum of care, meets legal and regulation standards, justifies the medical necessary for treatment and billing. Objectives include write a complete psychiatric note, documentation comprehensive psychiatric evaluation, writing follow-up medication management notes, documentation risk assessment, develop evidence-based treatment plan, and meet legal and billing requirements. So why the documentation matters? Good documentation demonstrates clinical reasoning, support the continuum of care, protect the clinician legally, and meets insurance and regulation requirements, facilitate communication with the treatment team. If it's not documented, it is assumed not have been done. Type of psychiatric documentations include initial psychiatric evaluation. This is the most comprehensive note and it used during the first visit. So the first visit component include the chief complaint, history of present illness, psychiatric history, medical history, surgery history, current medications, allergy, family psychiatric history, social history, substance usage history, review of systems, mental health status examination, risk assessment, diagnosis, differential diagnosis, and then treatment plan. So first, when you do the assessment, you want to talk to the patient what their chief complaint is, what brought them here to the hospital or to the clinic. This illness that they tell you that is the chief complaint, when did that begin? Do they have history of psychiatric illness? Do they have medical illness, history of medical illness? Do they have surgery? Have they had a surgery? Current medication that they taken, whether to the psychiatric medication or medical, if they taken for medical or psychiatric, or if this is a supplement, if they have any allergies, if their family has any psychiatric illness, social history, what do they do for work? Are they going to school? What is their social history? Substance usage, if they are what kind of substance they are using, have they been hospitalized, have they had a treatment with the substance. Then you will do the review of the symptoms, assess all the symptoms, and then mental status examination. We talked about mental status examination before. Risks assessments. Then you come up with the diagnosis, and then you make differential diagnosis. Those differential diagnoses include the diagnosis that similar or it could be relate to this chief compliant. Then you will set up the treatment plan. Then you will do the follow-up medication management note. Typically include the interval history, medication responses, side effects, medication compliance, mental status examination, risk assessment, update treatment plan. So this follow-up medication management notice is, for example, you prescribe a medication and you set up the follow-up appointment. So you want to review that. You want to review the interval of the follow-up appointment and how long they've been taking the medication, how they are responding to the medication, what side effects they are having with this medication that you prescribed. Are they compliant with the treatment? Do they been taking the medication whole interval or whole days that you set up the appointment? You will assess their mental status examination. You will assess the risk assessment. Then you do the assessment, review systems. Then you update the treatment plan. If you wanted them to continue, if you want to change the medication, if you want to add on to other medication. So that is the follow-up medication management note. There is also psychotherapy note. If you provide psychotherapy, you want to do the psychotherapy note. Psychotherapy note typically include the type of psychotherapy you provided, therapeutic intervention is used, patient responded to the psychotherapy, progress toward the goal is if they are progressing toward the goal. What is the plan for the future session? What do you want to do? You want to write down notes for that. There is a consultation note, and the consultation note includes reason for consulting this patient or this person, psychiatric findings that you find on them, diagnostic impression, recommendation that you made, discharge summary, include the hospital course, how long they've been in the hospital, diagnoses that you find, medications that they are on, follow-up recommendations that you make, and safety plans that you already write down and recommended. For the chief compliant should be documented in the patient's own words, whether it's possible. If it's possible, you want to write down what the patient says. I have been able to sleep for, I have not been able to sleep for 3 weeks. Could. Avoid fake statements such as follow-up anxiety, depression. You want to avoid those. History of present present illness tells the story of the current illness. And that you want to include your note. When did this present illness begin? Onset, duration, how long it been going on, how severe is this illness is, how frequent it comes, the cause of the illness, what trigger these symptoms, let's say symptoms. So the onset of the symptoms, duration of the symptoms, severity of the symptoms, frequency, how often it comes, of the symptoms, the course of the symptoms, what are the triggers of the symptoms, aggravation factors of the symptoms, relief of the symptoms, associated symptoms that relate to symptoms. When you have these symptoms, what else is happening? What are other symptoms that you noticed? Functional impairment, how these symptoms affect your daily function or task at work, at school, in the social context, how this symptom affect you. Let's say this patient come to you and say, I am seeing and hearing things, so they are hallucinating. But when did that begin? How long have they been seeing this visual hallucination? How severe it is? How frequent did they see this image? What trigger? What make them see the things? What aggravate these factors? Relieving factors. Do they see more hallucination when they are stressed, when they are tired, or do they see when they are asleep? Relieving factors. Do they still get the hallucination when they rest, when they are awake? How did that affect them, their work, their school, their social activities? Have they had a treatment before? For example, you have a 32 years old woman present with 6-week history of worsening depression mood. She say, I've been having a depressed mood for last 6 weeks, and I have a low energy, insomnia, decreased concentration, feeling of worthlessness, loss of interest in a previously enjoyment activities. Symptoms occur daily and have resulted in impaired work performance. It's hard for her to perform her job. You want to document the past psychiatric history that include previously diagnosis, psychiatric hospitalization, suicidal ideation or attempt, self-injury behavior, history of violent, previous medication that they've been taking, medication respond, how they responded to the medication they've been taking previously. Do they had any adverse effect? Previous psychotherapy, do they had any previous psychotherapy, and if they had, how did that help them? If they have electroconvulsion therapy, do they have repetitive transcranial magnetic stimulation? Have they had ketamine or esketamine treatment? Then you will document the medical history. Do they have a chronic illness? Do they have neurological deficit? Do they have endocrine disorders, cardiac disorders, surgical history of surgery, Are they having an allergic reaction? Do they have a history of allergy to the medication or to food or current medication that they are taking now? You want to assess the substance usage history. That include alcohol withdrawal, if they had alcohol, if they had alcohol withdrawal before. Are they using alcohol now? How often they use? Tobacco, ketamine, opioids, cocaine, methadone, hallucinogenic. You want to assist them. When do they begin? How long have they been having? Do they have a withdrawal symptoms? Do they have a treatment? Any of them? Caffeine. Do they use caffeine and that affected their sleep? Energy drink. You want to assess all that. You want to document the first age of first use. When do they begin smoking? How frequent they smoke? What the quantity they smoke? How much you smoke daily? Last time you used? If they're drinking, you ask the same questions. Withdrawal history. What treatment did they try? Or what treatment did they had? How did that work? Family psychiatric history. You will ask if their family member had a depression, bipolar, schizophrenia, anxiety disorder, substance usage disorder, suicidal ideation, dementia. Social history. You want to include childhood experience, education, employment, military service, relationship that they have or they had, if they are married or single, if they have children, housing, religion, legal history, if they had been incarcerated, trauma history, social support. And then you want to document and do the mental status examination. Mental status examination include the appearance, behavior, speech, mood, affect, thought process, thought content, perception, cognition, insight, judgment. Also, you want to assess suicidal risk, violent risk assessment explaining your clinical reasoning include diagnostic, impression, differential diagnosis, severity of the symptoms, respond to the treatment, medical decision making. Why do you choose this medication than this medication? Treatment plan. And then you want to document the treatment plan. This documentation include medication that you change, psychotherapy that you provide, laboratory test you made, reference that you refer to the patient, referrals that you make for the patient, follow-up appointments and the intervals, safety plan, education that you provide for the patient. Example of treatment plan documentation include continue Zoloft 100 mg by mouth daily, initiate cognitive behavior therapy referral, obtain a thyroid stimulating hormone and complete blood count. You set up a follow-up appointment for 4 weeks. You review the medication, risks, benefit, alternatives with the patient, and then the patient verbalize the understanding and agree with the treatment plan. You will document all that. Documentation of a medication management include medication compliant that patient is making, therapeutic response that they have, side effects that they complain about or mention, dosage changes, patient education that you provided, information consent that the patient signed, laboratory monitoring that the patient needs if indicated. Informed consent documentations include risk that you went over the risk and benefit and you educate them alternative to the treatment, potential side effects that they expect or may get from this medication. If there is a black box warning for the medication, you want to go over that and you want to document that. Patient questions, you want to write the patient questions and how you answer them. Agreement between the patient and you. Common documentation errors that you want to avoid is copying and pasting without updates, contradictory statement, missing a mental status examination, no suicidal risk assessment, no rationale for medication changes. You have to have a rationale why you change the medication. Judgmental languages, you want to avoid that. And supported diagnosis, you have to have a reason why you diagnose this diagnosis, how you come up with this diagnosis. Missing a follow-up appointment, those are what you want to avoid. Your documentation should explain why the treatment is needed, functional impairment that happen, symptom severity, risk of not treating. Yani if the patient is not taking this medication or doing this psychotherapy, what will happen? Expectation and benefit of the treatment. What are you expecting? What the patient should expect from the treatment? What do they get? Documentation objectively. Instead of objectively. Instead of saying the patient is lazy, which is unheard of, you want to have patient reports spending most of the day in bed and has not attended work for 2 weeks. Avoid speculation or emotional language. Record observation and patient statement clearly. You want to use the subnote format. Subnote is subjective, objective assessment, and plan. Subjective include the chief compliant, history of present illness, symptoms presented or complained about, medication compliant or adhesive, side effects that the patient reported. Objective is what you did, what you measure, like the vital signs, mental status examination, laboratory that you did and the result is. Assessment include the diagnosis assessment, clinical impression, risk assessment, differential diagnosis. Plan include the medication that you prescribed, psychotherapy that you refer or provided, laboratory monitoring that you want to do, education, follow-up appointments. For subjectives, you want to write down, I still feel anxious every day, but my panic attacks have decreased from 4 per week to 1 per week. Since starting a Zoloft. I have mild nausea but no suicidal thoughts. So that's what the patient is telling you. Then the objective is, example of the objectives include patient is alert, fully oriented, well-groomed, cooperative, speech normal, reading and volume, mood is anxious, affect mildly constricted but appropriate, thought process linear, goal directed, no delusion or hallucination, denies suicidal or homicidal ideation, insight and judgment are good. So it's the assessment you did, mental status examination. General assessment examples include general anxiety disorder with partial improvement on Zoloft, mild medication-related nausea that does not want a discontinuation. Suicidal risk is low based on denial of ideation, absence of a plan or intent, and presence of protective factors. Plan include continuous Zoloft, 50 mg daily, recommended cognitive behavior therapy, reinforce sleep hygiene, relaxation techniques, follow up in 4 weeks, educated patient regarding expectation timeline for continued improvement and sign of serotonin syndrome. Every note should include documentation of a mental health. Every note should include mental status examination and suicidal risk examination and assessment. The assessment should explain why you made the diagnosis and treatment decisions, not just list them. Documentation medication risk. Document medication risk, benefit, alternative treatment, inform consent, whether initiating or changing the medication. Psychotropic medications. Be objective, specific, concise, avoid judgment or fake language. A clear treatment plan should include medication management, psychotherapy recommendation, because you have to have both medication treatment and psychotherapy recommendations. Include monitoring. What to monitor: symptoms, labs, side effects. Patient education has to include safety plan and follow up. So clear plan should include medication management, psychotherapy recommendation, monitoring, patient education, safety plan, and follow up appointment. I have a question: is which component should be documented in every psychiatric follow-up visit? Which component should be documented in every psychiatric follow-up visit? Take your time. Suicidal ideation assessment. Which statement best example of an objective documentation? Objectives. Think about objectives. Objectives, what the provider did. Subjectives is what the patient is telling you. So, which statement is the best example of objectivist documentation? Is the patient avoid eye contact, speak softly, answers the question with 1 to 2 words, respond. That is the objectivist. You want to remember jam soap. For every psychiatric note, remember jam, CHAMB, SOAP, CHAMP, SOAP. Chief compliant, you want to remember chief compliant. You want history of present illness, assessment, mental status, plan, suicidal assessment, objectives, adhesive to the treatment and advice effect, patient education. So charm, soap. Thank you for joining me today. I would love to see you in my next video. Please subscribe and join me again.